This is chapter 34, Pediatrics. So obviously, pediatrics are going to be different than adults. A big thing is physically, emotionally, as well as like developmentally. Obviously, there's going to be some pretty significant changes. Um, Illness and injury and the responses to them vary on based on age and developmental level. It's really important that we remember that kids are not just small adults; they are very different. Um, they can also be pretty afraid of you if, they don't know who you are. You're a stranger, and what you're doing could be potentially pretty scary for them. So just try to be kind and caring, compassionate, and explain everything that you're doing. We'll talk about that. Once you kind of figure out how to deal with kids, at first they can be kind of scary because they're different. And, if you don't have children of your own, you may not be familiar with how to talk to them. But once you kind of get past that, you'll see that working with children can be incredibly rewarding, especially when you have positive outcomes and you get to kind of like touch base with them afterwards. It's really fun to see that they've made a wonderful recovery and that there's a positive outcome. When caring for an infant or a child, care for the parents also. Not only is this the child's worst day, but it's also the parents' worst day. So talk to the parents, let them know that you're doing everything that you can, and keep them informed. Let them know what's going on. Anytime you have a calm parent, generally you're going to have a calm child. The child's going to feed off of whatever the parent's emotions are. So if the parent is hysterical, that child's probably going to be pretty freaked out too. So when you do have a hysterical parent, do the best that you can to de-escalate. And if you can't, try to send them on a task. Maybe ask them for vaccination records or maybe a birth certificate, something that gives them a job, gives them a purpose. And it kind of, I don't want to say that it gets them out of your hair, but it kind of does. It opens it up so you can really assess the situation without the hysterical parent freaking the child out. Always be calm and professional. You have significant growth and developmental changes that are happening within the pediatric age range. We have pretty specific age ranges and names that are associated with those ranges. Infancy is going to be birth to the first year of life, so birth to 12 months. Toddler is 1 to 3, preschool 3 to 6, school age 6 to 12, and adolescent 13 to 18. The infant, so remember, first year of life. The first month, so birth to 1 month, is actually considered the neonate, but we kind of encompass that into infancy. Basically, the entire age range of infancy, they cry a lot. And it's pretty normal for them to cry a lot. When they cry to the point where they cannot be consoled, there's nothing that the parent or caregiver can do to get them to stop crying, then it becomes a medical emergency. We don't know what's causing the crying. And for all we know, the baby is cold or they're hungry or they're not happy, but there's a good chance that there might be something seriously wrong. So we're always going to err on the side of caution with an inconsolable child. I don't mean that they're crying for an hour. I mean that they're crying for an hour, 2 hours, 3 hours with absolutely nothing that the parent or caregiver can do to get them to stop. So 0 to 2, pretty much they eat and they sleep and they cry, and that's about it. 2 to 6, again, be concerned for persistent crying. Irritability, lack of eye contact, those can be indicators of serious illness, depressed mental status, delay in development. Those are not as much medical emergencies, but they are pretty serious and should be evaluated. 6 to 12 months, Generally, they're starting to have separation anxiety, so they don't want to be separated from mom or dad or caregiver. And again, persistent crying or irritability can be symptoms of serious illness. Overall, you want to observe from a distance. Don't get up in their face. They're not going to like you to begin with, so don't do anything that's going to make them like you less. Um, have the caregiver hold them. Do whatever you can to try to comfort them within a reasonable range. So if it's a pacifier that they want, is if it's a blanket that they want, a stuffed animal, something along those lines, maybe even just having caregiver hold them. Do what you can to try to help ease your assessment. If you have to do anything that's painful, save it for the end of your assessment, and do everything quickly, efficiently. Cut to the chase, get it done, get it over with. Don't, you know, hang out. I want to say don't lollygag, but that's kind of silly. Um, Explain everything that you're doing to the parent so they understand what's happening. Again, remember, this isn't just the child's worst day, this is also the parent's worst day. So the toddler, this is after infancy, so 12 months until 3 years. They're considered a toddler. At this point, they have rapid changes in growth and development. The development changes that are happening in this age category are astronomical. They're going from basically being a baby to walking, talking, having opinions, um, and knowing what they like and what they don't like. That's significant for 3 years. Actually, it's even 2 years because the first year doesn't count within the range. Between 12 and 18 months, they are not afraid of anything. They don't have any reason to be afraid. They've probably never been hurt. They've probably never had anything bad happen to them, hopefully. So they're not afraid. Unfortunately, with someone who's not afraid, they're more likely to have injuries. They may not fully be able to chew food. Some of these toddlers are really, really starting to really understand how to chew food and swallow. Remember, they've never done these things before. 18 to 24 months, separation anxiety is real. For your assessment, they're going to be afraid of you. Do the best you can to be nice. Don't separate them from the caregiver unless you absolutely have to. They're probably not going to be able to describe pain to you, either because their vocabulary is just not there yet, or they don't really understand. They can be distracted. Use that to your advantage. Try to get them to pay attention to something else besides what you're doing that may upset them. Start your assessment at the feet. Don't go right up in their face. Start at their toes. Count their toes. It might change things for you. Do what you can to kind of make things more fun. And again, persistent crying can be a symptom of serious illness. So preschool, this is 3 to 6. They are still at risk for aspiration of foreign objects. So even though they are potentially kindergartners, they can still choke on like an olive. So be aware of that kind of stuff. Generally, they can understand directions, be specific in describing painful areas, and much of the history is still going to be obtained from the caregivers. Communicate simply and directly. Don't use medical terminology. You don't have to dumb it down, but help them understand what's happening using basic words. Remember, you're talking to like a 4-year-old here. They're not going to understand, big terminology. Appeal to the child's imagination. It can help you. Never lie to a patient, especially if it's something that's going to hurt. Let them know about it beforehand, but then also let them know, if you hold still and you cooperate with me and help me out, then I may be able to only just do this once. I can get it right the first time. Still, you're beginning your assessment at the feet, moving up towards the head. Use bandages to cover the site of an injection or other small wounds. Modesty, they're kids. It's never a good idea to have naked kids They don't have very good thermal regulation, so we want to try to keep them covered simply because you can get them very cold very fast. They don't regulate their body temperature very well just quite yet. Um, but also, they're kids and they're naked and they're learning that they shouldn't be naked in front of strangers. So keep that in mind as well. Um, Try to have a parent present if you have to examine any part of their body, really, just any part, just simply because they're kids and they're super vulnerable. School age. So these are the kids that are attending school, 6 to 12 years. They're starting to understand death and some more complex concepts. Your assessment should be more like an adult at this point. You can talk to them about their care, talk to them about, how they're feeling, what's going on, ask those OPQRST questions. You're also still going to be getting a lot of it from the parents, especially on the younger end of that. But for the most part, they're going to be pretty comfortable with you at this point. This is not going to be their first rodeo, at least as far as exams go, because, they've got potentially 12 years worth of doctor's office visits. So they're going to be pretty comfortable with that. At this point, you can also start at the head and move towards the feet with your assessment, much like you would with an adult. Give the child choices, but control the answers. So instead of asking, "Can I get your blood pressure?" What if they say no? Then you're kind of screwed. Instead, ask, "I'm going to get your blood pressure. Would you like me to do it on your right arm or would you like me to do it on your left arm?" It's closed ended. It's doesn't give them the opportunity to say no. So ask questions that let you control the answer. Let them listen to your heartbeat or their heartbeat. Um, they can understand the difference between physical pain and emotional pain. So they understand, I'm crying because I'm sad or I'm crying because my stomach hurts. Provide simple explanations about what's causing the pain and what can be done. Again, you don't necessarily have to dumb it down, but explain it in simple terms. Ask the parent or the caregiver's advice. So, especially with handling, um, you know, when you're trying to figure out how to deal with maybe an emotional child, ask the caregiver, "How do I deal with this?" I mean, you don't necessarily have to straight up say it like that, but ask them how it's best to evaluate their child. They're going to know the child better than any other person. Adolescence, we should all be pretty familiar with this range. 13 to 18, most of us still remember it. Physically, they're similar to adults. However, emotionally, they're still very, very immature. This is a time of experimentation and risk taking behaviors: drinking, drug use, sexual activity, risk taking behaviors. They can often understand complex concepts and treatment options, so let them be a part of what's going on with them, or their own care. If at all possible, an EMT of the same gender should do a physical exam. Allow them to speak openly and ask questions. Female patients could be pregnant. Yes, I understand they are only 14 years old. However, it is possible. Do not be closed minded. Be open about it. Ask those very sensitive questions. And if they're not sexually active, then fabulous. If they are, it's important for you to know that there is a possibility of pregnancy. Have clear understanding of the purpose of meaning of pain. So they know that they're not just hurting because they know that they're hurting because there's something wrong. And generally, they can express that to you. So A&P, anatomy, physiology. Body is growing and changing very rapidly during childhood. We talked about this. Their first year of life, generally, they are going to be pretty close, if not actually doubling or tripling their weight, depending on how large they were at birth. Um, but that's significant. If you doubled your weight in a year, or if you tripled your weight in a year. I mean, that would be very significant. So really think about that. Understand the physical differences between the pediatric patient as well as the adult, and alter your care accordingly. Are kids more likely to have congestive heart failure, or are adults more likely to have congestive heart failure? Think things through. Respiratory system, the anatomy of airway differs from the adult. Pediatric airway is smaller, it's shorter in length, the lungs are smaller, they're more fragile. The heart is higher in the chest, the glottic opening is higher and positioned more anteriorly. The neck appears to be non existent. If you ever pay attention to a child or like an infant, you'll see that they really don't have much of a neck, really, at all. Where, older kids, they start to develop a neck, and then as they get older, their neck gets longer, their vocal cords become more developed, and their voice changes. All of that starts happening. Larger, rounder occiput, they have proportionately larger tongue, long, floppy U-shaped epiglottis, less developed rings of the cartilage of the trachea, which makes it very underprotected. So you can hyperextend their neck and actually kink their trachea. So it's very important that you're paying attention to what you're doing. They have a funnel-shaped upper airway. So you can imagine choking is still a huge issue. And then the diameter of a trachea in an infant is about the same as a drinking straw. So you can kind of get an idea of how small or large an object could be for them to be choking on it. Kids require more oxygen, about twice as much as an adult. Their diaphragm dictates the amount of oxygen inspired. So if they have, if they're constipated or if they have gastric distension, they have air in their belly, it's going to create pressure and push up on their diaphragm, which is going to make breathing more difficult. Breath sounds are going to be pretty easy to hear. They have a pretty thin chest wall, so you're not trying to listen through ribs and muscle and adipose tissue. It's pretty easy to hear. For the circulatory system, no normal pulse ranges. In your textbook, in the lifespan development chapter, there are several tables that have, they're fabulous resources that you can, maybe scan, shrink it down a little bit, and then print it out so you can have kind of a quick reference guide when it comes to vital signs on all of these different age ranges, and use that until you get comfortable. Children are going to compensate really well for decreased perfusion. So with adults, you have kind of like a steady decline when it comes to shock and compensating versus decompensating. With kids, it's like a plateau. They compensate incredibly well. They don't have significant changes, and then they suddenly drop off. They stop compensating. So kids can be pretty scary because you don't always know how close you are to that drop. So anytime you see any signs of poor perfusion, definitely, you should have a heightened index of suspicion that something is seriously wrong. Signs of vasoconstriction include being pale, weak distal pulses in the extremities, delayed cap refill time, cold hands and feet. Those are all big warning signs that something is very wrong. Here is one of those pulse rate tables. This one I don't like as much because, the numbers are a little harder to memorize. If you use the tables that are in the lifespan development chapter, they're a little bit easier to work with. So the nervous system, pediatric nervous system, it's immature, it's underdeveloped, it's not well protected. They're bobbleheads, so they have large heads, and it's like having a hammer. I know that sounds crazy, but it's like a hammer. If you were to knock it over, the head of the hammer, the heavy part, the large part, is going to hit the ground first. So that's how kids are. They have these, huge heads that are heavy, and they're not super great as far as proportion goes. So they're going to have some serious head injuries with falls. On top of that, their subarachnoid space, so the area that is around the brain, is pretty small, so they don't have a lot of cushion. So when they do hit their head, they're a lot more likely to have an actual injury to the brain itself. Um, and on top of that, the brain tissue and the cerebral vasculature is fragile and prone to bleeding from shearing forces. So all of those, it's a recipe for a disaster. Um, the pediatric brain requires higher cerebral blood flow, oxygen, and glucose. When a child has some sort of head injury, they're more likely to have secondary brain damage simply because, of bleeding or hypoxia or whatever is going on within the brain, whatever bruising or damage that's happening there is causing the brain to not get enough oxygen. And then you have hypoxic events or potentially hypotension. And then you have you're basically in shock at that point. Spinal cord injuries are not as common. Generally, they're more likely to kind of bend than break. If you have a suspected neck injury, perform manual inline stabilization, follow local protocols. The GI system, abdominal muscles, less developed. So if you think about it as like your abs, when someone comes up to you and they try to punch you in the stomach, you're instinctively going to flex your abdominal muscles. What this does is it protects your organs in that big, empty space. You don't have ribs there to protect your organs. You have your abdominal muscles. Kids don't have nearly as developed abdominal muscles as adults do, so they don't have that protection from their abdominal muscles that adults do. On top of that, their liver, spleen, and kidneys are proportionately larger. They're closer to the front of the body, which makes them prone to bleeding. And when one is injured, another one's probably going to be injured as well because they're so tight together. Musculoskeletal, kids have open growth plates in their bones, which allows them to grow. If there is a fracture or if there's damage at the point of a growth plate, it'll make it so that bone no longer grows. So it can be very serious. Bones are also going to be softer and more flexible, making them prone to stress fractures. We call fractures with pediatric patients green stick fractures. So if you think about a young tree that's still green, it's not dead, it's green, it's very flexible, and you try to break off a branch. It's not going to be easy. You really have to work at it because those fibers are, hanging on and they're flexible. So when you do break it, maybe the outside frays just a little, but then the inside of the break stays completely connected. This is what's going to happen when kids break bones or bend bones. They're kind of going to fray on the outside, but then stay connected on the other side. Infants' heads are flexible and soft because they have to pass through the birth canal. So things are not very well, solidified just yet. So unfortunately, that does make them more prone to head injuries. Additionally, the thoracic cage is highly elastic. It's very stretchy. It's not, super protective yet. And it will kind of harden and solidify with time. The skin, the integumentary system, the skin is thinner, there's less fat, the composition of skin is thinner and tends to burn more deeply and easy with exposure. They also have a higher body surface area to body mass ratio, which leads to larger fluid and heat losses. Again, they're poor thermal regulators. They don't regulate their body temperature very well, especially in the very young. So during your scene size up, your assessment begins at the time of dispatch. Anytime you have a call involving an infant or child, there's going to be added stress on you. So I recommend you talk to your partner, talk about what you can kind of expect based on your dispatch information, what kind of assessments that you should be working on. And things that maybe discuss vital signs, maybe discuss what your plan of action is going to be when you get on scene, depending on, what you see when you get there. Try to prepare for that. Um, of course, think about your equipment, your age appropriate physical assessment, all those kind of things that I just mentioned. Scene safety, note the position in which the patient is found. Patient may be a safety threat if they have an infectious disease. Don't be blind to the fact that kids also carry diseases. Just because they're kids does not mean that you're not going to contract anything from them. So you need to, protect yourself at all times, regardless of whether it's an infant or an 80-year-old man who's coughing on you. Do an environmental assessment. Make sure that the living conditions are good and healthy. If it's hot outside, make sure that they have air conditioning, they're clean, they have clothes on. If you get a chance, kind of peek in their fridge and see if they have food in the fridge. Are they an appropriate weight? Are their hygiene needs being met? All of those kind of things are considered environmental, as well as the adult's attitude towards the child and their level of concern. A traumatic scene where the child's unresponsive or too young to communicate. Assume there's significant injuries to the head or neck. Perform C-spine immobilization. For your primary assessment, use what's called the PAT, the Pediatric Assessment Triangle, to kind of guide you in your general impression. This is something that you can do from the doorway. You are looking at their appearance. Do they look sick? Do they not look sick? Are they, running around like a crazy little child? They're probably not that sick. Do they look limp and lifeless? Then there's probably a very significant problem. Work of breathing. Are they working hard? Or are they hardly working? Just kidding. Do they appear to be in distress? The celiac skin, do they have, normal color? Are they blue? Are they red? Are they yellow? Their circulation, you want to try to figure out everything all kind of put together. So appearance, work of breathing, and circulation. Something that you should be looking at from the door. It takes 30 seconds, and this is forming your general impression. Based on the findings, you decide if the patient's stable or requires urgent care. If they're unstable, then ABCs, life threats, drive fast. If stable, continue with the remainder of the assessment process. Hands-on ABCs. So really the only difference here that makes it hands-on is, you'll see here. So airway, we open it, we ensure that it's patent. If it's not, we fix it. Position it appropriately, make sure that you're keeping it open. Breathing, look, listen, and feel. Belly breathing is considered normal. It's adequate. Count their belly, rise and fall. Anytime you have bradypnea or slow breathing, it's an ominous sign and indicates impending respiratory arrest. So you need to be very concerned when they're breathing very slow. Circulation, get a pulse. Is there bleeding? Are they in shock? For infants, get a brachial or a femoral pulse. In kids older than 1, it's okay to get the carotid. Strong central pulses are usually, they don't indicate hypotensive problems. If there's a weak or absent peripheral pulse, it's indicative of decreased perfusion. So it's kind of an early warning sign here. Tachycardia can be early sign of hypoxia. Remember that when our brain detects high levels of CO2, we breathe faster, but then we can also increase our heart rate to try to circulate what we do have to perfuse those tissues. So tachycardia can be an early sign of hypoxia. Interpret pulse within the context of the overall history, PAT, and primary assessment. evaluate trends of increasing or decreasing pulse rates, check for skin CTC, cap refill time. Now, here's the differences. So, disability, get a pediatric GCS, get an AFHU, check pupillary response, look for symmetric movement of extremities. Pain should be present with injury. If there's no pain, then it kind of leads you to, it's of concern. Assessment of pain, you have to consider the developmental age of the patient. If they're, 6 months old, they're not going to be able to tell you the severity or what it feels like or if it's radiating. So, keep that in mind. And then E, exposure. Hands-on ABC requires the caregiver to remove some of the patient's clothing for observation. Again, they are more prone to hyperthermic events. Keep them covered, keep them warm. Also, if you have to expose them, most of the time you can cover them back up. If it's something that needs to remain exposed, like chest and belly to monitor breathing, then, turn the heat on in the ambulance. Do what you have to do to keep them safe. Transport decision. Determine whether rapid transport to the hospital is indicated. Rapid transport is indicated if it's a significant MOI, history of compatible with serious illness, potentially serious anatomic abnormality like spina bifida, significant pain, abnormal level of consciousness. Also consider the type of problem, the benefit or ALS treatment in the field, local EMS protocol, your comfort level. This is a huge one, especially with kids. Kids can be terrifying. So if you are really not comfortable with kids, you have no idea what's happening, and you're not sure if this is a serious problem or not a serious problem, call for help. Get ALS to rendezvous with you to the hospital. It doesn't, if you're ever in doubt, it doesn't hurt to ask for help. So when in doubt, ask for help. And then also consider your transport time to the hospital. If you are 30 minutes away and they're critical, light it up. Get there as fast as you can safely. If the patient's condition is urgent, initiate immediate transport to the closest appropriate facility. Here in Tucson, we have 2 pediatric ERs. We have Banner University main campus, and you have Tucson Medical Center Children's. So those are the 2 places that would be considered appropriate. So whichever one is closer. If the patient is less than 40 pounds, they need to be in a car seat. If it's like a code arrest, obviously they're not going to be in a car seat. Or if they're super critical, they're not going to be in a car seat. But if you can, they should be in a car seat. Put the car seat on the stretcher and follow manufacturer's instructions to secure the car seat to the captain's chair. I have a problem with that because it's going to be very difficult to take the patient into the hospital when they're strapped in to the captain's chair in your ambulance. Do what you can, strap them to the gurney, and make it so that you can roll them into the hospital. Patients who require spinal immobilization, use a longboard device or other suitable spinal immobilization device. Sometimes we can use KEDS vests for children, but you need to be shown how to properly do that for it to really work. For patients in cardiopulmonary arrest, use a device that can be secured to the stretcher. It says here don't use the pediatric patient's own car seat. However, that is definitely something that you do want to do. You want to use their own car seat because it's perfectly adjusted for them. The only time that you would not want to use their car seat is if it's been damaged in a car accident. So your goal is to secure and protect the pediatric patient for transport in the ambulance. For history taking. Sorry, my screen is going in and out. So approach to history depends on the age of the patient. History information for an adult, toddler, or preschool age can be obtained from the caregiver. Information is obtained from the patient in adolescence, and questioning of the parents or child. Questioning of the parents or child about the immediate illness or injury should be based on the child's chief complaint. Sorry. Questions to ask based on chief complaint: MOI, NOI, length of sickness or injury, key events leading up to the injury or illness, presence of fever, effects of illness or injury on the behavior, their activity level, eating, drinking, urine output, all of those things. If has there been any changes in bowel or bladder habits, presence of vomiting, diarrhea, abdominal pain, rashes. Get the name and the phone number of the caregiver if they're not able to come to the hospital with you. There's perfectly good reasons when they can't come to the hospital with you. So, like for instance, if they have 3 other kids to look after, it's not reasonable to bring all of those 3 extra kids with them to the hospital. So, they're likely going to be, hanging out at home waiting for someone to come over and take over care so they can then meet the child at the hospital. Sample history, it's going to be the same for adults as well as for kids. Questions should be based on age and developmental stage. For OPQRST, it's going to be the same. Again, questions should be based on age and developmental stage. They may have a hard time understanding radiation or severity. Just try to explain it to them in terms that they can understand. For physical exams, the secondary assessment of the entire body is used when patients are unresponsive or have significant MOI. Use DCAT BTLs just like you would with an adult. Your focused assessment should be performed on patients without life threats. Focused on the area of the body that's affected. This is going to be the same as with adults. For infants, toddlers, and preschool-age children, they should be assessed starting at the feet, ending at the head. School-age children and adolescents should be assessed using head-to-toe approach, just like you do with an adult. Make sure that you are examining all areas when it is necessary. For vital signs, like I said, go ahead and use the charts that are in the lifespan development chapter, because those are going to be the easiest to recognize, the easiest to memorize, and they have the appropriate age ranges as well. Again, I recommend that you scan it, shrink it down, print it out, and keep it with you for a quick reference guide so that you have something, that's a little bit more concrete than your memory when it comes to actually working out in the field, and at least until you understand, key vital signs or memorize key vital signs. Blood pressure is not typically going to be assessed in children under 3. But for kids over 3, we do have a formula for you. I believe it's on the next slide. Your skin assessment is going to be a better indication of circulatory status than it will be for adults, just simply because they are brand new. They have good circulatory systems. They haven't been abusing their circulatory systems with cheeseburgers and whatnot. So things are going to be working a whole lot better. When equipment is used, make sure that you're using the appropriate size. You cannot use an adult's BP cuff on a child's arm because it doesn't fit. You're not going to get an accurate reading. So here's that formula. So for blood pressure on children 3 and up, it says 1 to 10, but realistically, we don't get blood pressures on kids under 3. So 3 to 10, it's 70 plus twice the patient's age in years. So if they are 3 years old, you're going to do 70 plus 2 times 3 is 6. So 70 plus 6 is systolic blood pressure. So 76 is the kind of, textbook, I guess you could say, guide for blood pressure for a 3-year-old. Respiratory rates can be difficult to interpret. Count respirations for at least 30 seconds and then double the number In infants and those younger than 3, evaluate respirations by assessing the rise and fall of the abdomen. It is not uncommon for it to be somewhat irregular, and that's okay. If it's extremely irregular, then it's definitely a cause for concern and something that you should bring up with the provider that's taking over care once you get to the hospital. Pulse rate, you should count at least for 1 minute because, again, it can be irregular. So note the quality and irregularity, or I'm sorry, regularity. Normal pediatric vital signs vary with age. Assess respirations, pulse, and blood pressure. Again, use those charts from the lifespan development chapter. Evaluate pupils, compare the size of the pupils. Pulse oximetry is going to be a valuable tool for patients with respiratory issues. Reassess every 15 for stable, every 5 for unstable, just like you do for adults. Continually monitor respiratory effort, skin color condition, level of consciousness, interactiveness, all of that. You're going to continuously monitor and then get formal vital signs every either 5 or 15 minutes. For interventions, it may be in the child's best interest to have the caregiver assist you. So if they need a breathing treatment or if they need to use their inhaler, parent is going to be pretty familiar with the best way to go about it. So have them help you. Communication and documentation, document and communicate all relevant information to ED personnel. You are going to be the liaison between the parent and the hospital, at least for the first little bit. So help both parties. So help the parents and help the doctors and nurses. Respiratory emergencies and management. Respiratory problems, leading cause of cardiopulmonary arrest in pediatric population. Failure to recognize it will definitely lead to death. If they stop breathing, they are not going to survive for very long, so you definitely have to recognize it and fix it. Patients must work harder to breathe and will eventually go into respiratory failure if they're left untreated. In the early stages, you may note changes in behavior such as combativeness, restlessness, and anxiety. Signs and symptoms of increased work of breathing. There's going to be accessory muscle use, nasal flaring, head bobbing. So I believe that's actually a test question. Head bobbing. So like they're doing this. That's not normal work of breathing. They are struggling. They're moving their head back and forth because it's helping them open their airway. As the patient progresses to possible respiratory failure, the efforts to breathe are going to decrease. So when they start stopping, trying, that effort starts slowing down, this is impending doom. You need to get on it. You need to be more aggressive at this point because things are going to get really bad very fast. The chest rises less with inspiration, changes in behavior, and eventually altered level of consciousness when hypoxia really starts to kick in. As the patient progresses to possible respiratory failure, again, patient may experience periods of apnea, so when they completely stop breathing and then start up again. Again, these are impending signs and symptoms of impending doom here. Heart muscle becomes hypoxic. Respiratory failure does not always indicate airway obstruction. It can indicate trauma, nervous system problems, dehydration, metabolic disturbances. There can be brain issues, problems with their chemoreceptors. There's a lot of different things that can cause it, but how do we fix it? That's the more important key here. So make sure that their airway is open, make sure that they have adequate ventilation, and then make sure that they're also getting enough oxygen. As the patient progresses to respiratory failure, the condition can progress from respiratory distress to failure at any time. Child or infant needs supplemental oxygen. For infants and children in possible respiratory failure, assist ventilations with BVM and 100% oxygen. While still on scene, allow the patient to remain in a comfortable position, unless they stop breathing on you, and then you're going to want to put them on their back and, a head tilt chin lift so you can get good airflow. You need to keep that airway open. Airway obstructions. Most times, airway obstructions happen during eating with kids. But if they were just playing with a small toy and then they start choking and they turn blue, there's a good chance that they've choked on an object. Anytime at all, they've been dealing or playing with a small object, you can kind of expect that that's probably what caused their airway obstruction. Teeth can become airway obstructions in cases of trauma. Blood, vomit, other secretions can cause severe airway obstructions. Infections can also cause obstructions. If the patient has congestion, fever, drooling, and cold symptoms, you can kind of expect that there's an infection that's causing their airway obstruction. Croup and epiglottitis are upper airway problems that cause swelling and can occlude the airway. Obstruction by foreign body may involve upper or lower airway. So obstruction can be partial or complete. Signs and symptoms associated with partial include decreased breath sounds and stridor. Stridor is an upper respiratory obstruction sound. Signs and symptoms of lower airway obstructions include wheezing and crackles. Wheezing is a lower respiratory sound. Best way to auscultate breath sounds in pediatric patient is to listen to both sides of the chest at the armpit level. You are going for mid-axillary, so go from the armpit and then move down the ribs ever so slightly, and right there is going to be the best place to listen to kids' lung sounds. Immediately begin treatment of airway obstruction. Encourage coughing to clear airway when the patient is conscious and forcibly coughing. If you see signs of severe airway obstruction, attempt to clear the airway immediately. For infants, if they're conscious with a complete airway obstruction, perform black blows and chest thrusts, just like you learned in your CPR class. If they're conscious with a complete airway obstruction, perform abdominal thrusts, the Heimlich maneuver, again, learned within your CPR class. Use a head tilt chin lift and finger sweep to remove visible foreign body objects in an unconscious pediatric patient. If you cannot see it, we cannot go looking for it. You can use chest compressions to relieve a severe obstruction in an unconscious patient, but you're going to be alternating between chest compressions and ventilations to try to get that out if you cannot see it. And I would recommend using forceps instead of your finger, but if you don't have forceps available and you can see the object, you can attempt to pull it out. For asthma, the bronchioles become inflamed, they swell, they produce excessive mucus, leading to difficulty breathing. It's a true emergency if it's not promptly identified and treated. Common causes: exercise, seasonal allergies, dust, cleaning products, pretty much anything that can be irritating to the respiratory system can trigger an asthma attack. Signs and symptoms: a big one is going to be difficulty breathing and wheezing. Wheezing can be very loud with asthma patients. Treatment: meter dose inhaler. So they're going to have an inhaler prescribed to them, and if they don't, you can get authorization to do a breathing treatment, or you can call for ALS to have ALS do a breathing treatment, but they're going to need some medication, inhaled medication. For pneumonia, this is the leading cause of child's death. Pneumonia is a general term that refers to any infection that's within the lungs. Presentation in a pediatric patient: generally, they're going to be really fatigued. So super tired, not acting right. Maybe they're coughing. Maybe hopefully they're not cyanotic, but it's a possibility. Diagnosis of pneumonia must be confirmed within the hospital, and it's going to be treated with antibiotics in the hospital. Croup, very common. This is an infection of the airway below the level of the vocal cords. usually caused by a virus, typically seen in kids between 6 months and 3 years. It's easily passed between children. It's highly contagious. Hallmark sign of croup is stridor. So again, that's an upper airway noise, and a seal bark cough. This is very obvious. Once you hear it, you'll be able to diagnose croup from, next door. It's pretty telltale. Treatment for croup, generally, they're going to be receiving steroids and possibly antibiotics, more likely just steroids. And if they catch it quick enough, they can treat it pretty quickly. What are we going to do? We are going to do supportive measures. So if they need oxygen, we're going to give them oxygen. If they need ventilatory assistance, we're going to give them ventilatory assistance. If they just need a trip to the hospital, but overall vitals look great, then that's what we're going to do. They're going to be dealt with in the hospital setting or in the doctor's office. Not really anything that we can do specifically to treat croup. Epiglottitis. This is another test question regarding epiglottitis. It's a bacterial infection in the soft tissue in the area above the vocal cords. Incidence decreased since the development of a vaccine. Epiglottis swells 2 to 3 times to the normal size. The children look ill, report a very sore throat, and have a high fever. Tripod position, it's going to open up their airway for them or help open their airway. And drooling. Drooling is going to be one of those telltale signs for epiglottitis in children. Bronchiolitis. It's a specific viral illness in newborns and toddlers, often caused by RSV. RSV is respiratory syncytial virus. It can be very severe. And one of the big problems that results from RSV is bronchiolitis. It's more common in premature infants and results in copious secretions. It's also more common in boys. I don't know why, but it is. Look for signs of dehydration, shortness of breath, and fever. Nowhere on here does it really tell you what it is. Bronchiolitis, it is swelling and restricted passages in the bronchioles, and then excess mucus production. So you can understand why the combination of those two really is not a good combination. Treatment for this, sometimes they'll prescribe albuterol or in breathing treatment. Sometimes they'll prescribe steroids. Sometimes if it's really severe, they might attempt an antibiotic. However, this is going to be generally caused by a virus, so antibiotics are not going to do anything. Pertussis, this is whooping cough. They have a vaccine for it, which is really nice. But it's caused by a bacterium spread via respiratory droplets. Signs and symptoms are similar to a cold. You're going to have a telltale whoop noise when the patient is coughing. It'll be like a cough, 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 whoop, cough, cough, cough. If you don't understand what I mean, go ahead and get on YouTube and type in whooping cough, and you'll be able to hear what I'm talking about here. To treat patients, keep the airway open, transport. It's not something that you're going to be able to fix. Pertussis is contagious, so follow standard precautions, including wearing a mask and eye protection. This is something that you can contract as an adult, so be mindful, protect yourself. Again, just because they're kids doesn't mean that what they have isn't going to hurt you. Airway adjuncts. It's a device that helps maintain the airway or assist in providing artificial ventilation. Adults have OPAs and NPAs and bite blocks and all of these things. So you should be pretty familiar with it. Use the appropriate size. When it comes to ventilating, use the appropriate size BVM, the appropriate size mask. When it comes to keeping the airway open, use the appropriate size OPA and the appropriate size NPA. The OPA keeps the tongue from blocking the airway, makes suctioning easier, should be used for pediatric patients who are unconscious and in respiratory failure. NPAs, generally well tolerated, used for responsive patients, used in association with possible respiratory failure. So if you're worried that you might lose an airway, You can get a nasal trumpet or an NPA in before you lose it to kind of help keep it open. Generally, we're not going to be using this in kids younger than 1 because their skulls are still very soft. Their bones are not fully, fused together. So you do something wrong, you push a little too hard, you may actually penetrate soft tissues and end up putting it somewhere you don't want to be putting it. Shouldn't be used if there's any nasal obstruction or head trauma, again, for the exact same reason. And potential problems, if it's a little bit too long, it can stimulate a gag reflex. It can cause a vasovagal maneuver where they basically lose consciousness because you've stimulated their vagus nerve. Oxygen. We should be familiar with all of these, but as a review, blow-by. 6 liters provides 21% or more. Nasal cannula at 1 to 6 provides 24 to 44%. Non-rebreather at 10 to 15 liters is up to 95%. And a BVM at 10 to 15 liters provides nearly 100% oxygen concentration. Non-rebreathing masks, nasal cannula, or simple face masks are indicated for pediatric patients who have adequate respirations and or tidal volumes. BVM is going to be used for respirations less than 12 or more than 60, an altered level of consciousness or inadequate tidal volume. Now, just because they're greater than 60 doesn't necessarily mean they're going to go straight for a BVM. But if they're less than 12, then BVM's more likely than not definitely something that's going to be indicated. The blow-by method, obviously, it's going to be less effective than a face mask, but it's going to be easier for the child to tolerate. It doesn't provide high oxygen concentration, but it provides some oxygen. Nasal cannula, some patients prefer the cannula, some find it uncomfortable. It kind of depends on the age. Here you have some pictures. The child with the cup, this is a way that you can do blow-by. I find that kids are pretty curious about the stuff that we have in our ambulances. The whole idea behind using a cup is that it's something that they're familiar with, so they don't find it terrifying, I guess. I like to just give them a non-rebreather and let them hold it, let them play with it. They're very curious and they play with it and they end up getting, blow-by oxygen from it, and it's kind of a win-win. You don't have to fight with them. They want to play with it. They want to explore. It works. Non-rebreathers, when they are attached to the child's head, not just next to them, delivers up to 90% oxygen. BVM indicated in patients with too fast or too slow respirations, who are unresponsive, or who do not respond to painful stimuli. Here you have pictures of a non-rebreather and a BVM. To rescue a BVM, you should have learned this in your CPR class. Similar to one-person BVM, except one person has control of the seal, the mask to face seal, and one person has control over the bag and maintains the head position. Usually more effective than maintaining a tight seal because you have one person that's completely dedicated to the seal. So it's going to be better than the one person BVM. For cardiopulmonary arrest, not often associated with cardiac arrest in pediatric patients is most often, I was going to say, that doesn't seem right, most often associated with respiratory failure and arrest. Children are affected differently by decreasing oxygen concentration, and they become hypoxic, their heart slows down, they become bradycardic, and then they code. Shock. This is another one that we will kind of beat to death throughout the semester. It's a condition that develops when the circulatory system is unable to deliver a sufficient amount of blood to the organs. This results in organ failure and eventually cardiopulmonary arrest. Common causes of shock in pediatric patients, the most common, vomiting and diarrhea. So serious dehydration will put a child in shock within, it could be as little as hours. If they are having serious vomiting and diarrhea, they can become dangerously uh, hypovolemic or dehydrated to the point where they're going into shock. So it can happen very fast. Um, they respond differently than adults to fluid loss. Again, they compensate very, very, very well until they don't. Their compensatory mechanisms work very well. Things that you're going to see are increasing heart rate, increasing respirations, and then showing signs of paler blue skin. They may be, kind of starting to deteriorate. They may be more anxious. There's going to be, little things that you're going to be able to pick up on that, hey, something is wrong. Something's not right here. Treat shock by assessing ABCs, intervening as required. So any ABC problems, you're going to need to do something to fix it. It's never going to fix itself. The order becomes CAB if there's obvious life-threatening external hemorrhage or if cardiac arrest is suspected. Pediatric patients don't demonstrate a fall in blood pressure until shock is severe because, again, they compensate very well and then they don't. When they're showing a fall in blood pressure, that's when they're not compensating anymore. Limit your management to simple interventions. Don't waste time performing field procedures. Get them to the hospital as quickly as you can. Ensure the airway is open. Prepare for artificial ventilation. Control bleeding, high flow O2, or blow by if that's your only option. Continue to monitor the airway and breathing. Position the pediatric patient in a position of comfort. Keep them warm with blankets and heat. Provide immediate transport. Contact ALS as needed for backup. If they are in anaphylactic shock, this is a life-threatening allergic reaction. It involves generalized multi-system response. So this is a severe allergic reaction. You're going to have airway constriction. You're going to have vasodilation. So you can see signs of shock, so poor perfusion within the body, but then you're also going to have those airway signs. So you can see and hear wheezing very badly, possibly no air movement at all if it's more severe, swelling, hives, it can be quite severe. It can be quite distracting too. What are we going to do for it? We are going to contact medical control. We're going to let them know that we have anaphylaxis. We are going to administer their epinephrine. If they do not have a prescription for epinephrine, we are going to get ALS involved as soon as humanly possible so they can give life-saving epinephrine. This child is not going to just bounce back with oxygen. They need epinephrine to open up that airway or they can die. So it's very important that we get epinephrine on board with someone who is in anaphylactic shock. Bleeding disorders, hemophilia, it's congenital. Patients lack normal clotting factors. Most forms are hereditary and severe, predominantly found in the male population. Bleeding can happen spontaneously, and all injuries become serious because the blood doesn't clot and they can bleed out from something that's relatively minor. Altered mental status, there's all sorts of different causes. Understand developmental changes, listens to the caregiver's opinion. Not every 3-year-old is the same developmentally. Ask the caregiver what is normal for the child and assess how severe their altered level of consciousness really is. Signs and symptoms are going to vary depending on, all sorts of different situations. Treatment is going to focus on ABC and get them to the hospital. Seizures result in disorganized electrical activity in the brain. Manifests in a variety of ways. It can be very subtle in infants with simply an abnormal gaze, a sucking motion, like with their lips, and a bicycling motion, like with their arms or their legs. More obvious in older children with repetitive muscle contractions and unresponsiveness. You can also see like eyes twitching. That's an indicator of a seizure, as well as posturing. So if they kind of tense up and lean to one direction, That's another indicator of a seizure. Whole bunch of different causes. A lot of times we don't really know what's causing them, but if they've been evaluated by a physician, they might have a pretty good idea of what's causing them and how to prevent them. Longer and more intense seizures can take longer for the imbalance to correct itself. This is called a postictal stage. So the seizure creates this disorganized electrical activity. The brain's like, what on earth is going on? And it's just not functioning appropriately. The longer it's kind of going crazy, the longer it takes to recover. It needs time to reset and really get a grip on what's going on. If you have recurring or prolonged seizures, it can be considered life-threatening. Protect them from harm, call for ALS. ALS is going to be providing medication to help bring them out of a seizure. Until ALS gets there or until you get to the hospital, what you can do is high flow O2 with a non-rebreather and keep them from hurting themselves. So don't let them fall off the gurney. Don't let them smack their head against something. Outside of that, there's not really a whole lot we can do. So high flow O2, keep them protected while you take them to the hospital. Meningitis, this is inflammation of the tissues that covers the spinal cord and the brain. Being able to recognize a pediatric patient with meningitis is an important skill to have. Generally, there's a high fever, and we'll kind of go over those in, I think, the next slide or two. Individuals at a greater risk, males, newborns, compromised immune system, history of brain, spinal cord, or back surgery. So anytime their closed system has been open to an external source, they are more at risk. Children who have head trauma, shunts, pins, foreign bodies within their brain or spinal cord. Again, you're opening it up to a foreign something, a foreign substance, foreign body. They're more likely to develop an infection. Signs and symptoms are going to vary with age. A lot of times you see, I think we've got it on here. You have high fever, a stiff neck, they're not acting appropriately. Sometimes you have a pinpoint cherry red rash. If it's bacterial meningitis, it can cause death very quickly. So make sure that you're protecting yourself. You don't want to open yourself up to bacterial meningitis. Use an N95 mask and keep yourself protected. Here's that rash with meningitis. Patients with suspected meningitis should be considered contagious. Obviously, follow standard precautions and follow up to learn their diagnosis. Just because if it is something serious, you need to know about it so you can kind of watch for those signs and symptoms. Treatment, if it's bacterial, they can get you some antibiotics. If it's viral, it kind of has to run its course. So it really kind of depends. Most of the time, it's going to be supplemental in treating the symptoms. GI, never take a complaint of abdominal pain lightly. Monitor signs and symptoms of shock. Patients, complaints of gastrointestinal origin are common in pediatric patients. It could be just their stomach's upset because they're hungry. Their stomach's upset because they ate something bad. Their stomach's upset because they have diarrhea. All sorts of different reasons to have an upset stomach, but they can't really give you a good description, or they don't have as much life experience to know, oh, this is diarrhea because I ate something, this certain thing doesn't agree with me. Most cases, the patient's going to be experiencing abdominal discomfort, nausea, vomiting, and diarrhea. Appendicitis is also common. This is why we don't take GI complaints lightly. We pretty much just kind of expect the worst. Um, if you suspect appendicitis, get into the hospital for evaluation. Obtain a thorough history from the primary caregiver. Poisoning emergencies and management. Um, Poisoning is common among children because they are little explorers and they like putting things in their mouths, things that they should not be putting in their mouths, like Tide Pods or leaves from the plants. Signs and symptoms are going to be different depending on what they have put in their mouths. So what the substance was, the age of the patient, the weight of the patient, and how much they've actually consumed. They may appear normal, they could be confused, sleepy, unconscious. It really just kind of depends. Some substances take only one pill to be lethal. A lot of cardiac medications can kill children very, very fast. So it's very important to identify what they had access to. Be alert for signs of abuse. Um, let's see. After a primary assessment, ask caregiver the following: what was the substance? How much was ingested? How over what time? Um, any changes in behavior or level of consciousness, any choking or coughing after the exposure. You're going to take all of this plus their weight and age, and you're going to contact poison control. What's poison control's number? Something you need to know. The hotline is 1-800-222-1222. That's the national hotline for poison control. Our Tucson local number is 520-626-6016. An easy way to remember that is sick, too sick, sick, oh, I'm sick. Once you remember that, you'll never forget it. Treatment is going to be dictated pretty much by poison control, and then treating ABCs. So poison control will help guide you in what you need to be watching for and what you need to be doing, as well as how severe your issue is going to be. Poison control is just a big encyclopedia of all things poisonous. Hydration emergencies and management. It occurs when fluid loss is greater than fluid intake. Vomiting and diarrhea are common causes. They can lead to shock and death if left untreated. Infants and children are at a greater risk. Life-threatening dehydration can overcome an infant in a matter of hours. It can be mild, moderate, or severe. Your book has a good group of pictures and descriptions for mild, moderate, and severe. Your treatment is going to depend on how bad it is, but for the most part, you're going to be replacing fluids and then getting them to the hospital, and that's really all you can do. Fever emergencies, an increase in body temperature of 100.4 is abnormal. Fevers are rarely life-threatening. Common causes, infection is a big one. Sometimes teething can cause a fever, but it's not nearly as common. Most of the time, it's going to be, a minor infection. Results in internal body mechanism in which heat generation is increased and heat loss is decreased. Accurate body temperature is important for pediatric patients. Patient may present with signs of respiratory distress, shock, a stiff neck, rash, hot skin, flushed cheeks. In infants, they can have bulging fontanelles. Transport, manage ABCs. That's really all you can do. Febrile seizures. This is when you have a seizure because of a fever. Now, this is going to be on day 1 of your febrile illness. So it's not going to be like, oh, I've had a fever for 3 days. Now I'm going to have a seizure. The seizure is brought on because of a sudden spike in temperature. So a rapid change, not like 3-day gradual change. This is first day, sudden spike. Your brain says, I don't know what to do. And you have a seizure. Generally lasts less than 15 minutes with little or no postictal state. Maybe a sign of more serious problem, and like a seizure disorder, epilepsy, something along those lines. Management, we're going to treat it like a seizure. high flow tube, protect them, and take them to the hospital. Drowning emergencies and management. Take steps to ensure your own safety. Second, most common cause of unintentional death among children. Children younger than 5 are at most at risk. With adolescents, alcohol is frequently a factor. Principal condition is the lack of oxygen. Imagine that. A few minutes without oxygen affects the heart, lungs, and brain. Hypothermia from submersion in icy water. It can actually be a good thing to be not for drowning. Drowning is never a good thing. But in cold water, it's actually going to slow down your metabolism enough that you don't need as much oxygen as if you were submerged in warm water. So, I mean, if it's going to happen, hopefully it happens in cold water just because they have a much better chance of survival that way. Diving increases risk of neck and spinal cord injuries, especially if they're, diving in the shallow end. Never a good idea. Signs and symptoms will vary based on the type and length of submersion. So a lot of things to take into consideration. How long they were underwater, the temperature of the water, the clarity of the water. Like, was this a swamp or was this a swimming pool? Was this a bathtub? Those kind of things take into consideration and report back to the hospital. It's going to make a difference in, their recovery. Management, we are going to pull them out of the water. If they're not already out, we are going to assess them and manage what we need to. So if they're not breathing but they have a pulse, we're going to provide ventilation. We're going to suction. We're going to try to get some of that water out, and we're going to breathe for them. If they are in code arrest, we're going to do CPR. If you do need to do CPR and you put on your AED, make sure that you have them dried off and make sure that they're not in a puddle. Because again, you don't want to make yourself a patient here if you have to shock someone. Trauma emergencies. The number one killer in children in the United States. Quality of care can impact recovery. The muscles and bones of children continue to grow well into adolescence. Fractures of the femur is very rare. It can be a source of major blood loss if they do fracture their femur. Older children and adolescents are prone to long bone fractures because, they're prone to having fun, trying to fly, jumping off of high things. All of that kind of behavior is going to increase their risk of long bone fractures. Physical and physiological differences. Children are smaller. If you didn't know that already, kids are smaller than adults. So the location of injuries are different. So think about, a car. If someone is in the crosswalk and a car strikes them, if they're an adult and it's a low profile vehicle, they're going to hit their legs. If it's a child and it's a low profile vehicle, they're going to hit like their head and their body. So, the location of the injuries are going to be different just based on, their height and their size. Child's bones and soft tissues are less well developed than an adult. Force of injury affects structures differently. A child's head is proportionately larger and exerts greater stress on the neck structures during deceleration injuries. So like whiplash, remember, kids are these giant bobbleheads. So when you and I get in a car accident and we're rear-ended and we have whiplash, we can have some pretty serious problems. Children are going to have even greater problems because their head is so much bigger and their neck is that much more fragile. They're often injured because of underdeveloped judgment and lack of experience. So this is when they try to fly and they jump off the roof. Most adults have an idea that that's not going to work. Children may not always have that reasoning and are more likely to do stupid things because they just don't understand. Injury patterns, it's important for the EMT to understand physical and physiological characteristics of children. Psychological characteristics of children. Vehicle collisions, children will dart out in front of motor vehicles without looking, where adults are more likely to look. They typically sustain high injury high energy injuries to the head, spine, abdomen, pelvis, or legs, really depending on their height as well as the height of the vehicle. That is a test question. So remember that. Sports injuries. Children are often injured in organized sports and activities. Head and neck injuries occur with contact sports like football, wrestling, hockey. Probably not too much hockey here in Tucson, but it happens. Field hockey, soccer, lacrosse, any contact sport, they are likely to get hurt playing. Remember to mobilize the cervical spine if you have any reason to believe that they have a head injury. Head injuries are common in children because of the size of their head in relation to their body. They're bobbleheads. An infant has a soft, thin skull, which can result in a brain injury. It is still soft. So they hit the ground, they can, push their skull in a little bit and cause brain damage or brain injury. The scalp and facial vessels can cause a great deal of blood loss if not controlled. Nausea and vomiting are common signs and symptoms of a head injury in children. Anytime you have a head injury and then the child starts vomiting afterwards, that's a huge indicator that there's an injury that actually happened there. There's a brain injury, whether it's concussion or maybe something more severe. That vomiting is going to be indicative of a bigger problem. Mobilization. It's necessary for all children with possible head or spinal injuries after a traumatic event. Mobilization can be difficult because the child's body proportions. So when you put someone on a backboard, their head and their back end up lining up in a line. With kids being such big bobbleheads, you put them flat and their head comes forward. When their head comes forward, their airway gets kinked, so they no longer have an open airway. You need to keep all of this into consideration. So you can put something padding behind their back, elevate their shoulders up a little bit to keep their head in a neutral inline position so you don't lose their airway by putting them in C-spine. Chest injuries, usually the result of blunt trauma. The chest wall is flexible, so then their chest wall can cave in, damaging those organs that are underlying, and then you can also end up with a flailed chest segment. Abdominal injuries, common in pediatrics. Monitor all patients for signs of shock. If signs of shock, prevent hypothermia with blankets. High flow O2, get them to the hospital. So signs of shock and blood loss. With children, greater than 25% loss in blood volume increases the risk of shock. With adults, it's greater than 30 to 40%. So kids are going to be going into shock a little faster and a little easier with less blood volume loss than adults would be. Burns. Burns are considered more serious in kids than with adults. They have more surface area to relative body mass, which means the greater fluid and heat loss. Again, they're not good thermal regulators to begin with. So when we start damaging the system that controls the thermal regulation, we can see, a much more severe problem. They don't tolerate burns as well as adults. They're more likely to go into shock, develop hypothermia, and experience airway problems. Common ways that they're burned: exposures to hot substances, hot items on a stove, caustic substances. So it's not all just heat burns. It can also be chemical burns. Infection is a common problem. Use sterile technique anytime you're having to handle their skin. We have burn blankets that are basically just sterile paper sheets. So thermal regulation, again, is a big deal. So we want to cover them with blankets, but they've lost that protective covering on their skin. So we're going to put down this sterile sheet before we put the blankets on them, so we're not introducing bacteria. Consider child abuse in any burn situation. Even if it's that they pulled a pot of boiling water off the stove and it all makes sense, they shouldn't have had access to it. So you need to be mindful and kind of pay attention to the big picture, pay attention to the way the parent is acting. If they tell you that they pulled a pot off the stove, but it doesn't look like it, or maybe they're not tall enough to reach, then it's much more likely that it was an intentional burn. Keep your mind open to everything and absorb as much information as you can so you can help protect the child if the child is in an abusive situation. And in those cases, you can, report it to the appropriate agencies, and hopefully you can get that child some help. Severity is any child with burns to their body, it's going to be more severe just simply because they are very young. So burn severity, it's rated with like percentage of the body burned, any other associated complications, and then age as well. So just being young makes their burns more severe than an adult with the exact same burn. As far as treatment goes, we're going to treat them the same. We're going to cover with sterile dressings, keep them warm, high flow O2, get them to the hospital. Ideally, you want to try to get them to a burn center, especially if the burns are really severe. You might consider landing a helicopter and having them flown to Maricopa. Extremity injuries. Children have immature bones with active growth centers. The growth of long bones happens at the ends, at growth plates. They are potential weak spots. I already talked about grain stick fractures, where it doesn't completely break, it just more bends and causes damage. Generally, extremity injuries in children are managed the same way as adults. They're painful. Painful deformed limbs with evidence of broken bones should be splinted. Anytime it's painful and there's no evidence of broken bones, it's still probably a good idea to at least put a sling on, or do some like mild splinting, or just little bit of splinting. You don't have to go the full deal if you don't have that deformity, but splinting can help quite a bit even if there's not obvious deformity. It'll help with blood flow, it'll help with pain management, and sometimes it can even help with swelling. So definitely splint if you suspect a fracture, whether it's a displaced fracture or not. Pain management, first step is recognizing that the patient's in pain. Look for visual cues, use the Wong-Baker Faces pain scale. So 1 to 10 can be challenging for children. So instead, we can show them pictures of happy faces. So, 0 is like a very happy person picture, smiley face, whatever you want to call it. 10 is going to be a very, very frowny, crying picture. So you can ask them to point that out, or you can look at the patient's face and compare it to the Wong-Baker scale and figure out what number you would put them or give them based on their actual facial expressions, which smiley face matches their facial expressions. Interventions are limited to positioning, ice packs, extremity elevation, splinting, those kind of things. Sometimes oxygen can help with pain management. You can try distracting them with talking to them, asking them about other things. But as far as pain management, we really don't have actual pain management. You're going to need ALS for true pain management. Other important tool is kindness, emotional support. Be nice. Kindness goes a long way. It can make someone's day a lot better, just being nice. So, disaster management. Jumpstart triage system. This is intended for patients younger than 8, weighing less than 100 pounds. There's 4 triage categories, just like with adults. There's green, yellow, red, and black. So green, they're minor as far as injuries goes, not age-wise. So minor, not in need of immediate treatment. They're able to walk, except for infants, obviously cannot walk. Yellow is going to be delayed. So the presence of spontaneous breathing with peripheral pulse, responsive to painful stimuli, those are things that are going to categorize them as yellow. Red, immediate response. So apnea, responsive to positioning. So they're not breathing, but you give them a head tilt chin lift or jaw thrust maneuver, drop it in OPA, and their apnea is responsive. So they start breathing again, then they would be considered red. If you can also do some rescue breaths. Respiratory failure, inappropriate painful responses, those are all red. Black is going to be deceased or expectant deceased. So they're either already dead or they're pretty close to being dead. Apneic with no pulse. Apneic and unresponsive to rescue breathing. So you start that rescue breathing and nothing happens. It can be a very, very difficult decision to make, but you're doing this in a mass casualty situation. So you have maybe 10 patients to deal with, and you're just one person. You cannot focus all of your energy on someone who is not expected to survive. You need to focus on the people who have a chance. It sounds callous, but unfortunately, it's part of the job. There's a couple diagrams here. These are just flow charts. So are they able to walk? Yes. Then they're green. No. Okay. Are they breathing? Yes or no. Do they have a pulse? Yes or no. Are they appropriate or are they altered? You can kind of go from there. These flow charts are very, very beneficial when it comes to doing these mass casualty situations and triaging these patients. Child abuse and neglect, any improper or excessive action that injures or otherwise harms a pediatric patient, includes physical abuse, sexual abuse, neglect, and emotional abuse. Over 500,000 pediatric patients are victims of abuse annually. They may suffer life-threatening injuries, and if abuse is not reported, it's going to continue to happen. So anytime you suspect abuse, report it. If it's not abuse, then that's fine. That's great. You did your job by reporting it. If you report it and it turns out to be abuse, well, I don't want to say even better, but even better because you are helping that child get away from their abuser to have a better life. Signs of abuse. Generally, you're going to be called because of a reported injury to a child. Child abuse occurs in every socioeconomic status, so it happens in the very rich and it happens in the very poor. Be aware of the patient's surroundings, document the findings objectively. So don't write in your report that their environment was filthy, because filthy or dirty is different. One person's filthy is another person's clean. So instead, write objectively. There were piles of trash on the floor. There were rat feces. There's dead animal in the corner. Use objective vocabulary when you're writing your report. So that way, when it does get called into review, you paint a clear picture. And that's the goal here. You want to be as objective as possible. State facts, state exact findings. Don't make any assumptions and don't be vague. Don't say the house was dirty. Specifically state, what exactly you mean by that. Ask yourself the following questions. Is the injury a typical injury for the age of the child? The mechanism of injury reported, is it consistent with the injury? Do they have a handprint bruise in a one-story house and the caregiver says they fell down the stairs? Does that make sense? No, it doesn't make sense. Is the caregiver behaving appropriately? Do they seem to be concerned? Is there evidence of drinking or drug abuse or use at the scene? Was there a delay in seeking care? Is there a good relationship between the child and the caregiver? Does the child seem to want to be with the caregiver as opposed to being with you? If it's the other way around, that's not a good sign. If the child wants to cling to you as opposed to the caregiver, that can be an indicator that something's wrong at home. Are there multiple injuries at different stages of healing? So look at the coloring of bruises. Fresh bruises are going to be like a pink purple color. Older bruises are going to be on the green-yellow side. Are there unusual marks or bruises that may have been caused by cigarettes, grids, or branding injuries? So like, an electric stove, how there's a coil. Um, is there a coil pattern on part of their body? That's not something that's going to be an accident. That's something that's going to be intentional. Are there several types of injuries? Burns, broken bones, scabs, or bleeding areas? Any burns on the hands or feet that involve a glove distribution. So, for instance, you have a burn that is circumferential and it goes all the way over the hand like a glove. This is indicative that they were forcibly submerged part of their body into very hot, possibly even boiling water. If you go to touch water and it is too hot, you are not going to get your hand all the way in. You're barely going to touch it, and then you're going to instinctively pull away. So, anytime you have that glove distribution, that's not an accident. That's something that was done intentionally. Is there unexplained decreased level of consciousness? Is the child clean? Do they have an age appropriate weight? Is there any rectal or vaginal bleeding? What does the home look like? Is it clean? Is it dirty? Is it warm? Is it cold? Is there food in the fridge? The food that's in the fridge, is it appropriate food? And again, be objective. Child abuse mnemonic, it can help. Table 34-16, go ahead and take a look at it on your own time. Bruises, observe color and location. Again, the color of the bruise is indicative of the age of the bruise. Burns to the penis, testicles, vagina, buttocks, usually inflicted by somebody else. Burns that look like a glove are usually inflicted by somebody else. You should suspect child abuse if the child has cigarette burns or grid pattern burns. Fractures. The humerus and the femur don't normally fracture without major trauma. Falls from a bed are usually not associated with fractures. Shaken baby syndrome. Infants can sustain life-threatening head trauma by being shaken or struck. The shaking tears the blood vessels in the brain, resulting in bleeding around the brain. Neglect. This is refusal or failure to provide life necessities like water, clothing, shelter, personal hygiene, medicine, comfort, and personal safety. There's a thing called anxious avoidance disorder where the child has asked for comfort over and over and over again and has been continually denied comfort. So the child reaches a point where that child no longer seeks comfort because they know that they're not going to get it. That is a sign of abuse or neglect. Abused children may appear withdrawn, fearful, or hostile. You should be concerned if the patient does not want to discuss how an injury occurred. Parent may reveal a history of accidents, be alert for conflicting stories or lack of concern. The abuser may be a parent, a caregiver, a relative, or a friend of the family. EMTs in all states must report suspected abuse. Most states have special forms to do so. Supervisors are generally forbidden to interfere with reporting. Law enforcement and child protection services will determine whether or not there is abuse. Your job is not to determine if it is abuse. Your job is to recognize that the possibility exists and to report it. Sexual abuse, any age and gender can be a victim. Maintain an index of suspicion. Assessment should be limited to determining what type of dressing is required. Treat bruises and fractures as well. Do not examine genitalia unless there's evidence of bleeding or other injury that requires you to do something. Don't allow the child to wash, urinate, defecate until a physician completes an exam. You want to try to preserve evidence. Ensure an EMT or a police officer of the same gender remains with the patient. Maintain professional composure. Obtain as much information as possible from the child and any witnesses. Transport all children who are victims of sexual assault. Sexual abuse is a crime. SIDS, sudden infant death syndrome. This is unexplained death after a complete autopsy. So they've undergone a complete autopsy and we still don't know why that child died. About 3,500 infants die of SIDS annually. Babies should be placed on their backs in a firm mattress and a crib free of bumpers, blankets, and toys. Babies should sleep in the same room, but not the same bed, chair, or sofa as an adult. It's impossible to predict, but just gathering data, we have an idea of things that you can do to prevent it. Unfortunately, we still don't know what causes it, but we can try to help at least prevent it. Risk factors that we've noticed with statistics. Mothers younger than 20, the mother smoked during pregnancy, there was a low birth weight to begin with. It can occur at any time of day. You are faced with 3 tasks: assessment of the scene, assessment and management of the patient, and communication with and support of the family. Victims of SIDS will be pale or blue, not breathing, and unresponsive. Causes? We have no idea. We do not know. Begin with ABCs. Provide necessary interventions. Depending on how much time has passed, the patient may show post-mortem changes like blood pooling, dependent lividity, possibly even rigor mortis, where the body becomes stiff. If you see those signs, call medical control. If there's no signs of postmortem changes, begin CPR immediately. Note any marks or bruises on the child before performing any procedures. Note any interventions done before your arrival. Carefully inspect the environment, noting the condition of the scene and where the infant was found. Assessment should concentrate on signs of illness, general condition of the house, signs of poor hygiene, family interaction, and the site where the infant was discovered. You want to note, like, was there a bunch of blankets? Was there stuffed animals? Were they on the floor? Were they in a crib? Those kind of things. The sudden death of an infant is devastating for a family, tends to evoke strong emotion responses among healthcare providers as well. It's okay if you're not okay. Seek help. Your supervisors can help you with getting the help that you need. Allow the family to express their grief. The death of a child, in addition to medical treatment the child may require, you must provide the family with empathy and understanding. The family may want you to initiate resuscitation efforts, which may or may not conflict with your EMS protocols. If the child is obviously dead, then the child is obviously dead, and it's necessary to inform the parents or the caregiver that the child has died, and that at that point there's nothing more that can be done to bring them back. Introduce yourself to the child's parents or caregivers and ask about the child's date of birth, their medical history. Don't speculate on the cause of death. The family should be asked whether or not they want to hold the child. The following interventions are helpful. Use the child's name. Speak to the family members at eye level. If they're seated, sit down or kneel. Speak to the family at eye level. Use died and dead. It seems kind of harsh, but when someone is in that state of emotional distress, when you use words like passed away or gone, sometimes they don't really comprehend what is happening. It's important to use words like they have died. I'm sorry, but they are dead. Acknowledge a family member's feelings, but never say, I know how you feel. Even if you've gone through the exact same thing, you do not know how they feel, and you need to let them help them to understand that their feelings are valid. And by saying, I know how you feel, you are expressing that their feelings are not validated. Offer to call other family members or clergy. Keep any instructions short, simple, and basic. Ask family members if they want to hold the child. Wrap the child in a blanket and stay with the family while they hold the child. Do not remove equipment that was used in attempted resuscitation. Everyone expresses grief in a different way. Some will require intervention. Many caregivers feel directly responsible for the death of a child, and can be most likely they will be very emotionally distraught. Some EMS systems arrange for home visits after a child's death for closure. You may need training for these specific visits. A child's death can be very stressful. Take time before going back to the job, talk with other colleagues, be alert for signs of post traumatic stress in yourself as well as in others. Consider the need for help if signs occur. A parent life threatening event. So, this is when an infant is not breathing, they're cyanotic, they're unresponsive, but then they resume breathing and color with stimulation. This is called an apparent life threatening event. Classic apparent life threatening events is characterized by a distinct change in muscle tone, choking, or gagging. They may appear healthy and show no signs of illness or distress, must complete a careful assessment and provide rapid transport to the emergency department. This can be a warning sign, so you don't want to say, oh, well, they're breathing again. It's not a big deal. This is a big deal. Pay strict attention to airway management, assess history and environment, and allow the caregivers to ride in the back of the ambulance. Physicians are going to determine the cause. It's not your job to do so. So the review will actually take place within your classroom. Come to class prepared with questions. Hopefully, this was helpful, and you took breaks during this very long lecture.